I'm discussing about the management of diabetes during pregnancy. Management of diabetes during pregnancy is very crucial for maternal and fetal outcome. So let's review the uh, latest guidelines and key principles and the practical steps to have a safe and successful pregnancy. We all know the key component of good glycemic control is 3D. That is diet, discipline, and drugs. And I want to add another D here, that is desire or dream to control blood sugar. Actually, the management of diabetes in pregnancy starts before pregnancy, that is from the preconceptional period. So in preconceptional counseling, multidisciplinary team approach should be adopted. Evaluation and treatment of diabetic complications like retinopathy, neuropathy, nephropathy should be addressed, and importance of maintaining an euglycemic state before pregnancy should be discussed with the patient. HbA1c should be less than 6.5% to reduce congenital anomalies, and folic acid supplementation should be started from before pregnancy. Stoppage of oral hypoglycemic agents and starting insulin before pregnancy should be done, and switching to safer antihypertensive during pregnancy. Discipline includes the adoption of a healthy lifestyle and healthy food with adequate exercise. Moderate physical activity at least 30 minutes a day. Aerobic exercise, walking, swimming, and prenatal exercise are encouraged. Regarding medical nutrition therapy or the diet, the calculated nutrition and meal plan should be designed by a registered dietitian, and it will include 3 meals and 3 snacks. And for the calorie requirement, a woman with normal BMI will have 30 kilocalorie per kg per day, overweight will have 24 kilocalorie per kg per day, and the obese one is allowed to have 12 kilocalorie per kg per day. And the gestational weight gain should be like this. Women with normal BMI may have 11.5 to 16 kg weight gain during pregnancy, while the overweight are allowed 7 to 11 kg, and obese are not encouraged to have their weight gain more than 9 kg. And this is the calorie distribution. From the calculated calorie, the breakfast of a pregnant woman with diabetes will consist of 15% calorie, and the lunch will have the 30%, dinner will have the 30 to 40%, and 3 snacks each will contain 10% of the total calorie requirement. And calorie composition includes carbohydrate 35%, protein 30%, fat 20 to 35%, and unsaturated fats are encouraged to take. Here we see the plate of a diabetic woman in pregnancy. Here we see the half of the plate is full of green leafy vegetables, and 1/4 is full of proteins, and the remaining quarter is full of carbohydrates with low glycemic index. Now the pharmacotherapy. It is indicated when target blood sugar is not achieved by diet and exercise within 1 to 2 weeks, and the options are oral metformin and oral glibenclamide. In our country, we usually doesn't use glibenclamide. Here are some points about oral hypoglycemic agents during pregnancy. Generally, they are not recommended in pregnancy. Only NICE recommends oral hypoglycemic agent metformin during pregnancy. A large trial named MIG-TOFU trial, which is an Australia-New Zealand-based trial, concluded after 9-year study that the offspring exposed to metformin had a higher waist height ratio than and waist circumference than the unexposed. And metformin also increases the risk of prematurity. So insulin is the safest and the first-line therapy in management of diabetes during pregnancy. If blood glucose is not controlled by diet, exercise, and lifestyle modification within 2 weeks, American Diabetic Association ACOG 2018 recommends insulin therapy during pregnancy. Let's see what the PIGU recommendations are. They recommend when fasting plasma glucose level is 6.1 millimole per liter or more, 1 hour postprandial glycemia is more than 7.8 millimole per liter, we should start insulin. And when the woman needs pharmacological therapy more than 30 weeks, or diabetes diagnosed before 20 weeks, or pregnancy weight gain is more than 12 kg, we should start insulin. And NICE recommends if metformin is contraindicated or unacceptable, or if target blood sugar is not made by diet, exercise, or metformin, we should start insulin. And now the insulin therapy or insulin calculation. The total daily requirement at first trimester is 0.7 unit per kg per day. In second trimester, it is 0.8, and in third trimester, 0.9 to 1 unit per kg per day. And